Good morning. Welcome to New York. And I would echo comments in regards to this amazing team that we've been blessed to work with. Certainly, I started off in this Filmy journey with the Novadac team, with the great support staff over that table as mentioned, and really appreciative that when Stryker acquired Novadac, that the Filmy study was able to continue, even given that we were enrolling patients during the pandemic. So we are at a point now where we can present some really successful techniques and some very intriguing data. So this equipment that you'll see demonstrated in my talk is obviously functional approved equipment, but not for this specific use. And the procedures that you'll see are those that are done by me, and any information that I describe will be relative to my experience. So this is the Weintritt family back home in DC. And my wife is, who's obviously on the far right, she's a consultant, owns a consulting business with corporate law firms. And she always begins her talk, she tells me, I haven't actually seen one, about how she makes rich people richer and her husband saves lives for a living. And the corporate attorneys are always like, oh, Terry, it's great, it's breast cancer. And I always like to say, like, I'm married to a successful professional who gets to raise her rates every year. So in the beginning, I guess everything sort of has a beginning, and this, you can see one of the original Novadac spy systems. Actually, Dr. Venturi, who you'll hear talk next, unbeknownst to me, invited Novadac to come, and I think the first perfusion imaging case that was done in our healthcare system in Northern Virginia. And after I completed a bilateral mastectomy, it wasn't specifically this patient, but it was a similar case. Dr. Venturi said, we're going to now see how good you did, see what you've left me with. And I stayed, I can take it. And we saw really, for what I appreciate the first time learning about fluorescence imaging, and I'm sure you all had that same moment, and we will continue to, was, okay, this has literally been something we've been looking at our entire careers, and now we're seeing it in a different way. And it's a very meaningful way, and it's a way that we can, if there's an issue that's happening, we don't want to try and fix it in our office a week later, right? We want to fix it there in the operating room. But as a sidebar, after I sweated out a few minutes of the success of the perfusion, I then had a conversation with the person who was there supporting it about, honestly, I don't know anything about this technology. I feel a little bit guilty telling you that, and quickly dove into all these other applications and learned that there was a tremendous amount of information in the lymphatic space, yet a couple things. One, nothing was consistent, no specific protocol, very anecdotal. And the other is there was no respect for perfusion imaging in the world of plastic surgery. We know in the US, we're doing a lot of mastectomies, we're doing a lot of nipple-sparing mastectomies. We know the value that's proven in those cases for being able to perfuse the nipple-areolar complex. And all of the protocols that we would use relative to the visual dyes involve large volume injections into the subareolar space, which will make the plastic surgeon wish that they had never shown me this technology, because you cannot image that tissue. So as we set off to develop our protocol, we had those two things in mind. Just to give you an appraisal of some of the other data that's out there before I go into the data from our Filmy study. This is a meta-analysis published in 2019, and it ranks the known suspects relative to lymphatic mapping and breast cancer surgery, and it shows that both in detection rate and false negative rate, ICG ranks at the top. Another meta-analysis published in 2021, comparing, again, ICG relative to the use of radiocolloid agents alone, or in combination with blue dye or blue dye alone, and again, ICG compares favorably and superiorly to those agents. So much so that a conclusion, and this is over in the UK health system, was that fluorescence imaging for axillary sentinel notification is equivalent, et cetera, et cetera, et cetera. Considering the safety, considering the effectiveness, systems should consider incorporating this as standard of care, as improving infrastructure and the capability of hospital teams. And lastly, from a even more recent summary, 2022, a single institution publication for patients using the SPY-FI handheld system. So now we're looking at a contemporary study relative to outcomes, Similarly, a high detection rate and a number of lymph nodes that we're familiar with when we think about this is still a sentinel lymph node biopsy. So going back after that surgery with Dr. Venturi, within 2 weeks, I was at Novadac research in Vancouver with some interested participants, some not so interested, working on developing our protocol. It's a long flight, a lot of time zone changes. And what was derived from that was, first of all, the drug works for lymphatic mapping in literally any combination concentration amount. But we drilled down to something that would be similar to the technique that we use for TC99 as we're thinking about a head-to-head comparison, and something that would not preclude the ability for perfusion imaging. So normal strength essentially means you open up a kit, you take the vial of ICG, you take the aqueous solution, you mix the two together. That's normal strength. I use a TB syringe with 0.05 cc's at each site, and it's an intradermal, it's intraoperative, and it's immediate. And you'll see with the videos why all of those things really make this a very simple technique. So the study design, any patient who was a candidate for a sentinel lymph node biopsy who had not had previous complicated breast surgery was considered a candidate for this study. And the methodology that was used was an inpatient comparison where patients who enrolled in the Film B study initially would undergo mapping with ICG. A surgeon would remove the sentinel nodes only dictated by the fluorescent imaging. Once that was completed, all of these patients had had the institution's standard for nuclear injection for using a gamma probe device. And once the ICG mapping was completed, the axilla was then interrogated with the gamma probe. Any additional lymph nodes were removed, and each technology was used to assess the lymph nodes that the other had taken out. So a pretty straightforward comparison. Importantly though, surgeons were mapping with ICG alone and then using the gamma probe to make sure that if there was an issue, if we were missing lymph nodes, that it would be identified. Location sites and investigators across the US and Canada. And ultimately, we enrolled 148 patients with a total of 406 lymph nodes removed. So this would be what a typical injection procedure looks like. And this is real-time imaging, so that's slowed down or sped up. This would be the image modality that I think everyone is familiar with now. Fluorescent overlay just moved on to color segmented, and this would be, I call it pure SPI mode or pure fluorescence mode. So having a camera rolling at the time, and as you can see, a very short period of time, in patients with clinically negative nodes and healthy lymphatics, these are the ones that are candidates for a sentinel lymph node biopsy. You'll be able to visualize flow towards the regional lymphatics. And it's always some version of pattern in the periureter space, and eventually everything will converge, towards the axilla in this case, which is the target. And usually, even if there are multiple channels, by the time the transit occurs to the axilla, everything will coalesce to that node. So this has been happening for decades with injection of other agents, right? We've just never seen it. And one of the other things that is very compelling from a surgeon's perspective, and I have a video later to show really why that can be so helpful to have familiarity in this technology, is you know immediately that the injection worked. When you see flow to the axilla, you know that a lymph node is there. There is no doubt that that patient has been successfully mapped. This is another video in my clinical practice after the study showing how you would use this as a routine application for sentinel node biopsy. And in this patient, while we all have some degree of intent or desire for depth of penetration, those kinds of visualizations to continue to improve, you could actually see the lymph node through the skin transcutaneously. And as soon as incisions made in the axilla, it becomes very clear, especially in this patient who had a shallow superficial lymph node, and actually there were two, both very clearly delineated. This is that combination of white light and fluorescence overlay. So it allows color coding of the anatomy, which is a very simple way to put it. It allows the surgeon to know where the target is. It allows perspective relative to adjacent anatomy, and allows for a very accurate, safe, and effective removal of this patient's sentinel lymph node. And that is really, in essence, what lymphatic mapping for patients who are our patients who are candidates for sentinel lymph node biopsies looks like. Now, from an alternate perspective, this is where the ability to visualize the state of a patient's lymphatics, I feel, is very helpful. So the same person injecting, in this case, it's me. It's the same protocol, same locations as the other breasts that you saw. These are all right. In this case, within the few seconds after injection, it's a different pattern, though, that I'm witnessing. Instead of seeing that very clean uptake and very purposeful flow to the regional lymphatics, there's this stagnant sort of permeating pattern that's in the retrorenal space. This particular patient had a very extensive workup, as most of our patients end up having: MRI, ultrasound, clinical examination, looking at the axilla, and the nodes were clinically negative. Now, the cancer, primary cancer, was directly in the axillary tail. So I'm doing this case, and my deduction is that perhaps this patient's cancer is obstructing the flow of lymphatics from our usual injection site. And it's pretty rare that we do peritumoral injections. I thought about it, but I was leery to have Nuke Med inject peritumorally that close to the axilla. So we did the injection. The nuclear technique failed. There was no uptake or signal in the axilla. We moved into a peritumoral injection using ICG, and you can see in this sort of summary of the case from a photo perspective how in the pure fluorescence mode in the bottom left, there's the permeating pattern that occurred where the lymphatics were blocked. And we go back to that more clear, distinct uptake, lympho-like streaming pattern that you can in this area where they are distal to the obstruction. And the patient was able to successfully have a sentinel node biopsy, which was proven to be clinically negative. So going on now to the Film B study results. You've seen the applications. You've seen how it can be very impactful in our patients. So results of the Film B study. Primary endpoint was a comparison relative to non-inferiority against TC99. Now, this is a bit misleading based on the numbers. They're skewing. If you look at it from a pure perspective of how many nodes were identified with ICG versus TC99, clearly SPY is finding more nodes, and therefore in that version of a comparison, it's certainly not inferior. The average number of nodes is different, but not significantly different. With TC99, we had 1.8, and with ICG using the SPY-FI handheld device, 2.5. And I'll reiterate a bit here more about why that difference occurred and why it could actually be an important difference. Not so much necessarily dangerous, but actually could be helpful. When you question with that initial slide, 80-something%, 60-something%, did these investigators actually know how to use these agents? Each technique was successful as you would have predicted. So SPY-FI identifying a sentinel node, TC99 identifying a sentinel node, both worked very well. The difference really came in a setting of the number of nodes that also correlated in patients who had metastatic disease. So in the 40 lymph nodes that were assessed in the study that ended up being positive, so in pathology, none of these were clinically positive, but in final pathology, positive lymph nodes, a greater percentage of them, 88% versus 75, were identified using SPY technology compared to TC99. And that was per patient as well as in the overall total number of lymph nodes. When we went and looked back at some of these cases specific to, okay, I know we interrogated each lymph node with both techniques, so let's go back and look into some of these more carefully. And there were positive lymph nodes that were found with SPY that were considered negative by TC99 that actually did have, in some cases, some activity, but it was below 10%. So for those who are familiar with how we sort of conduct safely sentinel node biopsies is if there's a drop-off in the nuclear technique of less than 10% and those lymph nodes are clinically negative, they're left alone. Well, we actually found that some of those lymph nodes had cancer in them, and that perhaps we have created a structure where this 10% rule may actually be a bit detrimental. No, the initial genesis was to have surgeons not take out 10 lymph nodes and call it a sentinel node procedure, but that protocol is fairly well established. Given that ICG is not asking or telling a surgeon to remove more nodes, at least from a statistically significant perspective, yet it's finding additional lymph nodes that are true sentinel nodes and that are harboring disease, we look at that and think that more of an assessment of it is a sentinel node or it's not should be removed and provides useful information. So here we are today. Again, this would be a case in my practice, and this is a little bit of a blend of the mapping and perfusion patient who's undergoing a reduction oncoplasty. And in this particular case, plastic surgeon, one of Dr. Weintritt's partners, was interested in doing perfusion imaging of the skin envelope associated with surgery. Typical injection technique, my promise that, number one, we can sometimes inject it in skin that's removed. Number two, it's not going to interfere with your ability to visualize. And the same pattern of clean, clear uptake, the same purposeful transit to the axilla. Now, it's a wide exposure here. It's patients having a reduction approach. So we're using that whole flap to expose the axilla. But this is the value relative to what we cannot see with our own eyes, and that this technique shows. And it's so clear, both the initial afferent lymphatic to sentinel node number 1, and in this patient, number 2, both removed, both clinically negative. By the way, this patient also, for some reason, did not have a very clear signal using TC99, even though this institution, it's a lymphoseek injection, everything appeared to be done very well. And not only was it a successful method of mapping, but it saved the patient from having to have additional surgery. In the last video, patient who had a reduction, had an oncoplastic excision for calcifications that were benign from radiology biopsy. It felt to be discordant, underwent excision by me in surgery center setting, ended up coming back with DCIS with microinvasion, so brought back now for sentinel node staging based on it being a high-grade ER-negative DCIS. How the technology is used to both inject, visualize, confirm flow, help identify where the afferent lymphatic is diving deep, mark where the sentinel node should be, dissect below the axillary fascia, see that lymphatic channel heading to a lymph node, all of this using white light and fluorescence overlay imaging, and successfully and safely identify and map and remove the sentinel node. And I have rescue indicated here again because similar situation. This patient had nuclear medicine injection, which will eventually change once we move on to a different phase, with this technology and its status, and it didn't work. We know these techniques have a very high rate of success, but nothing's 100%. The problem is when I'm operating on a patient, they're on the table. If the injection technique, which I'm expecting to work, but I can't actually see it move from point A to point B, isn't giving me the information that I expect it to, then if I don't have a technique like this, then I have to decide, am I going to commit this patient with microinvasion to an axillary dissection? Or am I going to not do lymphatic staging in someone who has a lot of high-grade DCIS with microinvasion that's ER negative that we know can be a very dangerous disease even with systemic recurrence? If I inject this patient, as I did, with ICG using the Film B protocol, and there's no flow, and I know that it's not because of a cancer that's between the point of injection and the axilla, then there actually could be pathology within the lymph nodes, and I would be motivated in that case to actually go and do some lymph node sampling. But it would be clear to me the reason why, or in this case, it actually was a technical issue. Technical issues happen. But when the surgeon can confirm whether it's real disease or whether it's based on technique, and in this case, rescue a patient from having either no procedure or an overly aggressive one, that's a tremendous added value for technology in our practices. So conclusions from the Film B study and my own experience in the use of ICG. So we see from data around the world and from Film B that ICG compares very favorably. Favorable probably is an underestimation. It compares superiorly in most cases to other techniques for sentinel node identification. The meta-analyses, the institutional reviews, all show a combination of good detection relative to cancer, low rates of false negative, and similar numbers of lymph nodes removed. It's the only surgeon-controlled, immediately visible agent that can give us a real clear state of affairs, of our patients relative to their anatomy and their disease. And when an alternate injection may be needed, or when we may need to sort of rescue a patient, from something based on other techniques technically failing, we have the ability to do that. And surgeons love to be able, the sight, of their tissue. We really believe a lot what we see and feel. And I have learned to become a believer in when I see this very clear, purposeful flow that I refer to as lymphostreaming, I know that a lymph node is mapped. The technique is successful. Now it's on me and the technology to go and find it. Yet when there's a cloudy pattern, there's an issue anatomically, biologically, but again, that's my job to fix it, but I can't do it if I don't have the right technology. So I'm going to end this with a couple of pictures. So when I have had the opportunity over the past 5-6 years to discuss this technique with other surgeons, I'll get, as you can imagine, a few different reactions. Quite often though, it's, I'm good, what I'm using is fine, I really don't need this to disrupt my practice. So that would be my 2 boys last year in the Keys as we're heading out fishing. Now they had previously not gone offshore, and this was a pretty windy day. So I'm telling them, guys, this is different, right? We're about to go into something you've never done before. You may want to prepare yourself with a little Dramamine or something like, Dad, no, we got it, we're good, we know what we're doing. On the way home. Nobody wants to be caught in that situation. And when we've been there, we know we don't ever want to do it again. And I would say, that the use of technology like this, helps keep us out of situations like that. And when we have been there, we'll be thankful to have tools like this to never be there again. Thank you.
Thank you. Thank you, Dr. Weintritt.